Hello doctors. Today we are here with abdominal trauma. Starting with the abdominal trauma, the most common trauma type is the blunt trauma of abdomen. And most common injured organ in trauma is the spleen. So, in blunt trauma abdomen, most common injured organ is spleen, followed by liver, then small intestine. Most common organ affected in penetrating injury is liver, small intestine, and then followed by diaphragm. Remember this. After liver, it is small intestine, not spleen. That is for penetrating injury. For gunshot injury, most common organ which is injured is small intestine, followed by liver. In deaccelerating injury, the duodenojejunal flexure is the most commonly affected site, and in seat belt syndrome, mesentery is the most common affected site for the seat belt syndrome. So, most common organ affected in blunt trauma is spleen. In penetrating trauma, it is liver. For gunshot injury, it is small intestine. For deaccelerating injury, it is duodenojejunal flexure. In seat belt syndrome, that is from the that is in the mesentery of the bowel. And overall, most common organ I have told you, that is the spleen. So workup, if we do the workup, if a patient comes to you in the trauma with blunt trauma in abdomen, if first you have to see whether the patient is hemodynamically stable or the hemodynamically unstable patient. How do you know hemodynamically unstable? Unstable means there will be decrease in BP, patient might be unconscious or semi-conscious, there will be increase in pulse rate, increase in respiratory rate. This will tell you that the patient is hemodynamically unstable. If the patient is hemodynamically unstable, then go for fast procedure. Now it is now which is done, that is eFAST procedure. This is the first investigation, and this is also the investigation of choice for hemodynamically unstable patient with abdominal trauma. And if the patient comes to you with hemodynamically stable, means BP, pulse, respiratory rate, urine output, all these things are normal, then the first investigation that you will do will be the fast. But if you are asked in the question, what is the investigation of choice, then it is CECT of abdomen and pelvis. It is not fast. If it is asked, what is the first investigation? First investigation is always fast in both the cases, but investigation of choice for stable patient is CECT, and investigation of choice for unstable patient is fast. Then what is fast? Fast is focused assessment sonogram in trauma. That is the full form of fast. Focused assessment sonogram in trauma. That is ultrasound in emergency room. In emergency room, there should be an ultrasound, and the probe are placed in 4 places in cases of fast. The first place where the probe is placed, that is subxiphoid space or epigastrium, to look for the cardiac tamponade. Below the xiphisternum, we have the manubrium sternum, then body of the sternum, then we have the xiphisternum. Below the xiphisternum, we put the probe. That is the first place where we put the probe. And from here, we can see the heart. So this is the first place, subxiphoid space, to see if there is any kind of cardiac tamponade present or not. Then the right upper quadrant is the second place where we put the probe to see the liver and the hepatic space. And the right upper quadrant, after right upper quadrant, we see the left upper quadrant to see the splenic collection, and then we place the probe in the suprapubic area to see the pelvic collection. And what is the advantage of this? This advantage is of fast is that it is very quick, very fast. We can do this very quick procedure, can detect as little as 50 to 100 cc of fluid. Only 50 to 100 cc of bleeding can be detected by fast procedure. But the disadvantage of this procedure is it is operator dependent. This is the common disadvantage in all the kind of USG procedure that we'll do, because USG is done by an radiologist, and that is operator dependent, whether the radiologist is good enough or not. So that is the disadvantage. Apart from that, we cannot see retroperitoneal injury. Like if there is any injury in the pancreas, kidney, then we cannot see that. So retroperitoneal injuries can be missed in cases when we do the fast procedure. We have seen this is the fast procedure. What is eFAST procedure? eFAST means extended fast procedure. What is extended fast? Extended fast means we have placed probes in 4 places in cases of fast procedure, but in eFAST procedure we place the probe in 6 places. Apart from that similar 4 places, we keep the probe in 2 more places, that is in the left and the right thoracic cavity. In the left and right thoracic cavity also we put the probe, that is known as eFAST, to see any kind of hemothorax or any kind of collection in the chest can be seen via the extended FAST procedure. What do you mean by fast positive? Fast positive means there is hyperechoic areas, means there is collection present, and fast negative means there is no collection present, which is generally normal. So what are the advantages and utilization of the fast procedure? Number one, it detects the free fluid in the abdomen and pericardium, will not reliably detect the less than 100 ml of free blood, does not directly identify the injury to the hollow viscous, cannot exclude injury in the penetrating trauma, may need repeating or supplementing with other investigation, and is unreliable for assessment of the retroperitoneum. So these are the utilization. So what are the utilization? We can detect free fluid, but we are not sure if very less amount of bleeding is present. It might not get detected by eFAST. And eFAST even does not directly identify any kind of hollow viscous injury, is not identified by eFAST. We cannot rely for penetrating injury. We cannot rely only on eFAST. We need further investigation. We might need further investigation, and we might have to repeat eFAST because single eFAST is not a single investigation to rely on. And as you know, the disadvantage is also there, that is we cannot see any kind of retroperitoneal injuries. So now we will see blunt trauma in abdomen. Suppose we have done the abdominal examination. On abdominal examination, we have found there is presence of peritonitis, or patient is hemodynamically unstable and fast test is positive. Peritonitis means patient might have guarding or rigidity present in the abdomen, or hemodynamically unstable, plus we have done the fast and we have positive fast, means there is echogenic collection present in the abdomen. If there is echogenic collection present in the abdomen, then we have to do explorative laparotomy, midline laparotomy. We have to open the abdomen and we have to do the procedure accordingly. But if there is no peritonitis, no hemodynamical instability, when patient is stable and there is no peritonitis, then we have to go for, after fast, we have to go for abdominal CT scan. In the CT scan, if we can detect whether there is an hollow viscous injury, we might detect it via the pneumoperitoneum. Even small amount of pneumoperitoneum can be detected in CT scan. So we have to see whether there is a hollow viscous injury present or not. If it is present, then we have to do the explorative laparotomy and manage accordingly. Or if there is no hollow viscous injury, there might be a solid organ injury present, like liver injury, spleen injury, or even a kidney injury might be present. If there is solid organ injury present, then we will manage accordingly. If there is no solid organ injury present, if there is no hollow viscous injury present, then we have to manage other small injuries that is present in the patient. And if there is pseudoaneurysm or atrial blush on contrast CT scan, if it is present, then we have to call the interventional radiologist and do an angiography. And if there is no such pseudoaneurysm or atrial blush present, then there is no need for any kind of operative management in these kind of patient. So I will repeat. First, you have to tell whether the patient is stable or not. If the patient is stable, then go for CT scan. If there is peritonitis, go directly for operative procedure. After doing CT scan, look whether any kind of hollow viscous injury present or not. If there is any hollow viscous injury, go for explorative laparotomy. If there is no hollow viscous injury, look for a solid organ injury. If there is a solid organ injury present, then we have to treat them accordingly. And if there is no solid organ injury present, then we have to treat other minor injuries. And if there is any pseudoaneurysm or atrial blush present, then we have to call the interventional radiologist for evaluation and do an angiography. And if there is no such pseudoaneurysm, then no further major operative management is required in this patient. So now this is about the blunt trauma abdomen. Now we will see the penetrating abdominal trauma. For penetrating abdominal trauma, here also first you will have to see whether the patient is stable or unstable. If the patient is stable, there is no peritonitis. penetration superficial to the peritoneum. There is no peritoneal breach, means peritoneum is intact, peritoneum is not injured. Then local wound care followed by CT scan. First we have to do the local wound care, then we will send the patient for CT scan. If the patient is stable, we have to send the patient for CT scan. But if the patient is unstable, there is features of peritonitis or omentum is hanging out, there is an abdominal injury and omentum is hanging out from that injury, or any kind of bowel, a segment of jejunum, ileum, or any segment of bowel, even a very small segment of bowel if hanging out, means there is a peritoneal breach. If there is a peritoneal breach, then we have to do laparotomy. Without doing any investigation also, you have to do laparotomy in these patients. So if there is a stable patient, we have to do the CT scan. If there is a penetrating injury, hanging out bowel or omentum is hanging out, features of peritonitis or bile staining is present, then you have to do a laparotomy, midline laparotomy. So this is about the penetrating abdominal trauma. And if the patient present to you in the emergency with a knife inside his abdomen, a part of the knife is penetrating inside his abdomen, then never remove the knife. Always remove the instrument or knife in the OT. When you are taking the patient for operative management, in the operating theater, you should remove the object. So never remove an object in the emergency room, should always be done in an OT. Now, evaluation and management of anterior abdominal wall stab. Suppose anteriorly there is a stab wound. Now, patient might present, as you know, first thing that you have to see, that is whether the patient is stable or unstable. If the patient having a features of shock, peritonitis is present, then we will have to do explorative laparotomy, and we have to localize the injury. Where is the injury? It might be in the flank or back. If it is present in the flank or back, then we have to do CCT of abdomen, pelvis, and generally rectal contrast is given from the anal area, from the anal opening. You have to give an contrast, rectal contrast is given. And if any kind of injury is present, we might need explorative laparotomy. If it is negative, then you can discharge the patient or you can observe the patient via admitting. If there is anterior abdominal penetrating trauma is present over the anterior abdomen, then CT of abdomen is again done. Then serial abdominal examinations are done. If facial violation is present, means if there is breach in peritoneum, as told earlier, if there is any kind of breach in peritoneum, do explorative laparotomy or diagnostic laparotomy. If there is negative for breaches, then we might do diagnostic laparotomy, or we can just observe the patient and admit the patient. If there is a thoracoabdominal injury, means in the region of the chest, at the junction of the chest and abdomen, if at that region there is an injury, then we have to suspect and evaluate for the diaphragmatic injury. And for that we have to do chest x-ray, we have to do pericardial FAST and diagnostic laparoscopy. We might need to rule out the diaphragmatic injury. And after ruling out if there is a diaphragmatic injury, we have to repair the diaphragm, generally repair with Prolene 1 suture. And if there is no diaphragmatic injury, then we have to observe the patient. So these are about the penetrating injury. Remember, whenever a patient comes to you with trauma, whether it is a blunt trauma abdomen or a penetrating injury, you have to first see whether the patient is stable or not. First see whether the patient is stable or not. Then we have to do the next step. So this is the stepwise evaluation for blunt trauma injury and penetrating abdominal trauma. Another thing that you have to know, that is diagnostic peritoneal lavage, DPL. This is diagnostic peritoneal lavage. Diagnostic peritoneal lavage are not done nowadays, as eFAST is much more easier to do and better. Therefore, diagnostic peritoneal lavage are not done. Diagnostic peritoneal lavage also cannot exclude retroperitoneal injuries. So after stabilizing a patient, put RT and Foley's catheter. After putting an RT and Foley's catheter, just below the umbilicus, aspirate with a 10 ml syringe. Aspirate. If there is 100 cc of blood comes out from just below the umbilicus, then it is known as positive DPL, diagnostic peritoneal lavage. If 10 cc of blood does not come out, then infuse 1 liter of saline or RL, that is lingual lactate. Infuse 1 liter of saline or RL, then aspirate again. In aspiration, send the aspirated sample for the cytology. If there is presence of more than 1 lakh RBC or more than 500 WBC per millimeter cube, or serum amylase is more than 175, means there is a pancreatic injury, or if there is a fecal content present, if any one of this is positive, if any one even of this is positive, then it is known as DPL positive and we have to go for laparotomy. So this may be asked in MCQ. First is that if there is a 10 cc of blood comes out, go for laparotomy. If there is no blood, then we have to infuse 1 liter of saline or RL, lingual lactate. After that, you have to aspirate again and you have to send that aspirated sample for cytology. If there is more than 1 lakh RBC per column, or if there is more than 500 WBCs per millimeter cube, or serum amylase is more than 175, or fecal content present, then it is known as DPL positive and you have to go for laparotomy. Now we will see the splenic trauma. As you know, most common organ that is injured, overall most common organ that is injured is spleen. Most common organ injured in blunt trauma is also spleen, and most common organ injured in children is also spleen. So this is the most, these are asked in MCQ. Now when you will suspect a splenic injury, when there is fracture of 9 to 11th ribs on the left side. Over the left side, if there is 9th to 11th rib fracture, as spleen is located over the 9th and 11th rib and spleen is along the 10th rib. So if there is rib fracture along this, then you have to suspect a splenic injury. If there is bruising over the left lower chest, if there is a bruising present over the left lower chest, then also suspect for splenic injury. And if there is Keher sign positive, what is Keher sign? Keher sign is rise of left lower limb. What is Keher sign? Keher sign is blood accumulates beneath the left dome of the diaphragm, because spleen is present over the left side. When there is injury to the spleen, there is bleeding from the spleen present and the blood accumulates beneath the left dome of the diaphragm. And from the left dome of the diaphragm, there is a referred pain over the left shoulder tip. This is known as Keher sign and this is positive in cases of splenic injury. Now you have to know the grades of splenic injury. It is very important and asked in MCQ very commonly. So remember, there are 5 grades: grade 1, grade 2, grade 3, grade 4 and grade 5. There are 5 grades, remember first. Now grade 1 splenic injury means laceration is less than 1 centimeter parenchymal depth or subcapsular hematoma is less than 10% surface. This is known as grade 1, means laceration is less than 1 centimeter, means depth of penetration is less than 1 centimeter and subcapsular hematoma is less than 10% of surface. Grade 2 is laceration of 1 to 3 centimeter of subcapsular hematoma is 10% to 50%. Grade 3 is laceration is more than 3 centimeter or subcapsular hematoma is more than 50%. Grade 4 is laceration of segment or hilar vessel with significant devascularization and more than 25% of the spleen is devascularized. So for grade 4, remember this. Grade 4 is there is hilar vessel injury and more than 25%. It is asked in NEET SS exam also. That is more than 25% of the spleen is involved, not less than 25. It is more than 25% devascularization is present. And grade 5 is completely shattered spleen or hilar injury with complete devascularization. So grade 5 is completely shattered spleen. So remember these grades of splenic injury. Now, if there is grade 1 and 2, grade 1 and 2 means the laceration is less than 1 centimeter or 1 to 3 centimeter or the subcapsular hematoma is up to 50%. Then generally the patient is stable. Investigation of choice is CECT and we will manage the patient conservatively. Monitor the vital, monitor the hematocrit and serial 24-hour CECT is done. Or if the grade of injury increases, when we repeat the CECT after 24 hours, if the grade of injury increases, and there is a contrast blush present, then we have to do angioembolism in this patient. If the angioembolism fails or the patient is unstable or if there is no contrast unstable, then we have to do surgery. Surgery that we do generally, either we do splenography or we do splenic preservation. Out of these two, we do the surgery that we do in grade 1 and grade 2. So In cases of grade 1 and grade 2, usually we observe the patient. After 24 hours, we repeat the CCT. If there is no abnormality in CCT, then we continue to observe the patient. If there is contrast blush present, then we do angioembolism. After doing, if angioembolism fails or the patient is unstable, then we go for surgery. The surgery that we do, that is splenography or splenic preservation. Now, if the grade of injury is grade 3, then either the patient, if the patient is stable, it is managed similarly as grade 1 and grade 2. But if the patient is unstable, then we will manage it like a grade 4 or grade 5 injury. So what we will do in grade 4 and grade 5? Grade 4 means there is hilar injury, more than 25% devascularization of spleen, and grade 5 means completely shattered spleen. In these cases, generally the patient is unstable and investigation of choice is eFAST or FAST. Then we do the surgery, and generally in these two cases we do splenectomy. In grade 4 and grade 5 we do splenectomy, and in generally grade 1 and grade 2, if requires, we do splenography or splenic preservation. Remember this is very important. Now, what are the precautions? Because we have to see the complication that can occur in splenectomy. Number 1 is hemorrhage. Number 2 is injury to the pancreatic tail. Spleen is present and pancreas is also present near it. So while doing splenectomy, we might injure the tail of the pancreas. So there might be injury to the tail of the pancreas, and if there is injury to the pancreas, then there will be turbid discharge in the drain. The abdominal drain that we will put after OT, there will be turbid discharge, and the drain fluid will be rich in amylase if there is injury to the pancreas while dissecting the spleen. Or there are hematological changes. These changes are also asked after doing splenectomy, whether it is an elective splenectomy or emergency splenectomy. After doing splenectomy, there is transient increase in WBC, RBC and platelet for 2 weeks. For 2 weeks, there will be increase in WBC, RBC and platelet. And this is temporary. After 2 weeks, they will be normal. But there will be permanent increase in basophilic stippling. There will be permanently basophilic stippling will be present in peripheral smear or Howell-Jolly bodies, reticulocytes and hyperpigmented WBCs are present in permanent changes that occurs after splenectomy in a patient. When we do the peripheral smear, we can see this. So this is important. What are the hematological changes that can be asked? Now, what is OPSI? That is overwhelming post-splenectomy infection. Spleen is a lymphoid organ. We get an immunity from it. So OPSI, that is overwhelming post-splenectomy infection, that occurs generally within first 2 years of splenectomy. OPSI occurs. It is more common in children than in adult. And if the splenectomy is done due to hematological causes like hereditary spherocytosis, hereditary elliptocytosis or ITP, if in that case splenectomy is done, the rate of OPSI is much more. If the splenectomy is done because of trauma, the chances of OPSI is very less. So if OPSI occurs, then there will be high mortality in the patient. So it occurs in first 2 years of life, more common in children. Splenectomy done for hematological conditions have more chances of OPSI and it has high mortality. Most common organism for OPSI is that is Streptococcus pneumoniae, Haemophilus influenzae. First is Streptococcus pneumoniae. Most importantly, Streptococcus pneumoniae, Neisseria meningitidis and Haemophilus influenzae. These three are very important. And fourth organism, if it is asked, then it is E. coli, which also causes OPSI. Children who have undergone splenectomy before the age of 5 years should be treated with daily dose of penicillin until the age of 10 years. If we do a splenectomy in a 5-year-old or less than 5-year-old child, then we have to give daily dose of penicillin until and unless the child becomes 10 to 12 years of age. Remember this, we have to give daily dose of penicillin for those children. So, but in cases of adult, if we do an elective splenectomy, then the vaccination is given 2 weeks prior to the operation. And if patient came to you with a trauma, splenic injury grade 5, when you have done a splenectomy, then in post-operative day 2, we give the vaccination. Most common complication, this is asked many times in NEET PG exam. What is the most common complication after splenectomy? The most common complication after splenectomy is left lower lung atelectasis. This is the most common complication following splenectomy. Remember this. Now we will see the liver injury. Liver is the most commonly injured organ in penetrating injury, but majority of liver injury occur in blunt trauma. Remember this. Majority of liver injury occur in blunt trauma, but most common organ injured in penetrating trauma is the liver. You remember we have 5 grades in splenic trauma, but remember we have 6 grade in liver trauma. Grade 1, 2 and 3 are same as that of spleen. That is, one have subcapsular hematoma less than 10% surface area and subcapsular tear less than 1 centimeter depth. Grade 2 is subcapsular hematoma is 10 to 50% of the surface area and intraparenchymal hematoma is less than 10 centimeter in diameter. Laceration is 1 to 3 centimeter depth. Here another point that is added in this is that intraparenchymal hematoma is less than 10 centimeter in diameter. Grade 3 subcapsular hematoma is more than 50% and intraparenchymal hematoma is more than 10 centimeter and laceration is more than 3 centimeter. Grade 4, remember in grade 4 there is disruption of 25 to 75% of the hepatic lobe. Remember this. Grade 4 have 25 to 75% of hepatic lobe injury or 1 to 3 coinyard segment are injured. In grade 5, more than 3 coinyard segment are injured and more than 75% of the hepatic lobe have been injured. That is grade 5. And here grade 6 is known as completely shattered liver or hepatic avulsion or vascular injury is present. That is grade 5 of liver injury. So this is the grading of the liver injury. 1 to 3 is same as that of spleen. In spleen, grade 5 is known as shattered spleen, but in liver, grade 6 is known as hepatic avulsion or shattered liver. Grade 4 is 1 to 3 coinyard segment is injured and in grade 5 more than 3 coinyard segment is injured. Remember this. So in grade 1, 2 and 3, generally the patient is stable. We do the CECT and we observe the patient and do a conservative management. But in cases of grade 4, 5 and 6, we have to explore the patient. After exploration of the patient, if there is a bleeding present, then we have to do 4 P's. What are the 4 P's? That is push. Push means we have to push the liver. We have to do a bimanual compression. You have to push the liver or we have to do a Pringles maneuver. We have to plug via the Sengstech and Blackmore tube and we have to do packing. This is packing means we have to create a tamponade effect around the liver. This is known as packing. And what is Pringles maneuver? We have the in foramen of Winslow, we have the hepatic pedicle and we have to compress the hepatic pedicle. If it is asked what constitutes the hepatic pedicle, that is hepatic artery, common bile duct and portal vein. So when we are pressing the in foramens of Winslow, we do the Pringles maneuver. If the bleeding continues, means that is not a content of hepatic pedicle because we have already compressed the hepatic pedicle. So hepatic pedicle doesn't have hepatic vein. If the bleeding continues, means bleeding is from hepatic vein. But if the bleeding stops, then either it is from hepatic artery or it is from portal vein. So this is for Pringles maneuver. In every 15 to 20 minutes, we generally release the Pringles maneuver, then we again clamp it. This is known as Pringles maneuver that we do in cases of liver injury with grade 4, 5 and 6 liver injury. If there is hepatic artery injured, if there is hepatic artery injury is present, either we ligate the hepatic artery or we repair the hepatic artery with Prolene suture. And if portal vein injury is present, we need to repair it. We cannot ligate the portal vein as we ligate the hepatic artery. Remember this. And if there is a common bile duct injury, repair it over an T-tube. We have to repair the common bile duct injury over a T-tube. So these are the all for the liver injuries. Now, small thing that you have to know, that is the mesenteric injury. Mesenteric injury is when there is a longitudinal tear. This is the mesentery. Okay, this blue line is the mesentery, white line, this is the bowel, and this is the in perpendicularly there is supply of the vessels present. So if there is a longitudinal injury, then we can repair it. Just we can repair the tear, we can do the primary repair. But if there is a transverse injury, then you can see if there is a transverse injury, there is cutting of blood supply to that part of the bowel. If there is a cutting of blood supply, there is no blood supply, means there will be ischemia and necrosis of that bowel. So in these cases, we have to do resection and anastomosis. We will resect this segment of bowel and we will anastomose the fresh segments of bowel. Viable part of the bowel will be anastomosed. So in cases of transverse tear, we have to do resection and anastomosis. And in cases of longitudinal tear, we have to we can do a primary repair of the tear. So this is all about today for abdominal trauma part 1. We have covered penetrating injury, blunt trauma injury, FAST, eFAST, diagnostic peritoneal lavage. We have completed the splenic injury and the liver injuries. In our next part, we will progress with other organ injury like kidney injuries, duodenal and pancreatic injuries, and other sections of blunt trauma and penetrating trauma of abdomen and abdominal trauma. Thank you for watching, guys. Please do like, share and subscribe to my channel so that I can make more free videos for all the medical students out there. Thank you.